Thank you. So I don't have any relevant disclosures, but I do have to say that I do have to disclose that I'm Canadian, and American politics scares me, I have to say. So I am neither Republican nor Democrat, so I hope that this talk is fair and balanced and doesn't come with that lens. Let's see. So I've asked a number of you, some of you sitting in the audience, what you think value-based care is. And guess what? It's like a snowflake. Every answer is different. But there are some themes that seem to carry forward in our conversations. It's this shift away from a volume-based model, which is our traditional model. A shift away from the fee-for-service model, which we're used to practicing in. And one of the reasons that this shift is occurring because we're trying to avoid duplication and inappropriateness. Another important point that some people are picking up on and some are not is that the provider, so either the physician or the healthcare facility, is assuming some risk. And I'll delve into that a little bit more because I think sometimes that's not clear. Why is this change happening? Why is this disruption happening? Well, it's been felt that the fee-for-service healthcare model incentivizes facilities to order more tests and procedures and manage more patients in order to get paid more, so regardless of patient outcomes. And so it's kind of a backlash to this where we're moving towards a value-based care where each member of the team shares both risk and reward. You can see they're very happy about that, with incentives to improve access to care, quality of care, and patient outcomes while reducing costs. So what does that actually mean? So this is a traditional pricing model where a company comes up with a product or echocardiographers come up with a test known as an echo. And we think it costs us $80 to do an echo, but we want to have a little bit of benefit, so we're going to charge $100 for that. And so that's the value out in the market. It's a $100 test, and that's what our customers see. I'm not sure who the customer is, and it's not clear to me whether it should be the patient or the health insurance company, but that's part and parcel of the cost pricing model. So with value-based, it's flipped. So what they say is that the patient comes first, or the health insurance company comes first, I guess, and they decide how much an echo is worth to them. They might say, you know what, I think an echo is only worth $50. Or they might say it's $200, right? But they're deciding on the price. Let's say they decided it was $50, and so now that's your price. And even though it costs you $70 to perform an echo, you're going to provide a $70 echo perhaps for $50. Or you might be providing a $70 echo for $100, depending on what the value has been placed on that test. So I would say value-based care is a animal with many different features, and other features are that it helps us coordinate many different types of tests, and it does place some risk towards the provider, and I'll explain what that means as well. It's very important for us to understand what this model is, though. Lazard is a business company that has clients around the world, and they polled 300 global leaders, executives, on what they think is going to be the most disruptive to healthcare in the next 5 to 10 years. Guess what? It wasn't demographics, it wasn't technology like 3D or strain or anything like that. It wasn't AI, it was value-based care. They feel that this is going to be the most important disruption that we have to understand. How do we fit into this? How do Echo Labs fit into this value-based model? Well, it's about helping to define that price point, that value. And to do that, quality is very important. So we have to make sure our product is very high quality. That's our top priority. Delivering the best product at the lowest cost in terms of resources. So how can we do that? Here's an example that was conducted at Massachusetts General Hospital, where they looked at the quality of their product. They realized that they were developing some rates of inter-observer variability in their reporting. And so you can see that different participants were reporting the same study with an ejection fraction that was slightly different. And then there was one person that was kind of out to lunch that day, but most people were hovering around that. And so this group asked, how do we improve quality in the Echo Lab? Could we do a teaching intervention, for example? So they instituted a 12-week intervention. You know, the first step is always denial. You have to get past that step and then move forward. They basically talked about why inter-observer variability is occurring. What was causing one person to give a different answer compared to another person sitting next to them? And what they found was, after instituting these quality interventions, they in fact were able to reduce inter-observer variability significantly. And so this is a way of introducing quality and reporting that you have high quality outcomes coming out of your laboratory. And you can do that for other simple quality measures in your lab as well, as long as it's done in a sort of a supportive, mentoring manner. Another important part of creating value for your product is coordinating POCUS with echocardiography, so point-of-care ultrasound, as well as other imaging modalities, and trying to decide what is the best test first and how does it integrate with our traditional echocardiogram. Comparing studies is important, and reporting the comparison of different studies is important as well. Dr. Baird published recently that there are some advantages to echo compared to some of the other modalities with respect to portability, cost, and radiation risk. So we really have to keep this in mind, that this data is out there, and we really do have to advocate for our product. So here's another example when we think about what is value-based care. This doesn't encompass all facets of value-based care, but helps. It's a sort of a thought exercise for us to understand. So let's say my summer barbecue budget is $1,000. So I could buy, a top-of-the-line barbecue. It's about, $1,500. So I'll have to borrow a little bit, but I'll have a really nice barbecue. Or I can get, a nice one from Costco. It's about $400. Or I can go to Canadian Tire. That's sort of our Walmart, I guess, and I can buy a nice barbecue for under $100. So dinner for me, probably I can just use this barbecue, right? And I'll have enough money left over to have, say, 10 barbecues over the summer. Dinner for my family, I could probably use this, but I might have to I'd probably be better off using a larger barbecue because I've got 4 people in my family. And so maybe I'll have fewer barbecues, but they'll be good barbecues. A dinner party would work as well in this situation. A reception for my neighbor. This would be a bit of a stretch, wouldn't it? I'm not sure. I probably could manage. It may not be the best party. This would be the best, but I could only do one big barbecue this summer, and my budget is blown, right? So this is sort of a value matrix, thinking about what instrument is best for the condition that is being presented to you at that time. And so if we think about some of the conditions we see in cardiovascular disease, palpitations, chest pain, chronic dyspnea, you're going to start off with ECG, history, and physical, but you have some additional tools available to you. Palpitation, sure, you want to reassure the patient. You might do a quick POCUS scan in your office, and they're off. An echo might be a little bit excessive, but if you have it handy, you might do that. Chest pain, you know what? You don't want to do the POCUS. You want to get a good look at wall motion abnormality, so you're going to go for an echo. Chronic dyspnea as well. Yeah, I think it makes sense to start with an echocardiogram. CT, fine, that's the gold standard. We really want to look at the lungs, right? But what test has the most check marks? So thinking about what test actually brings value. And it may not be perfect in all situations, but it does provide value moving forward in terms of diagnosis for a patient. So the other concept is that value might be created with new technologies such as point-of-care ultrasound to help us triage and identify appropriate echoes. So if we think about the fact that echo is a different animal than point-of-care ultrasound, an echo is more like a beaver to me. It's sort of industrious, likes to build a home base, quality, education, guidelines. That's all why we're here. Cardiovascular POCUS is the new disruptor. So more quality and education is needed, but it can be done in real time, and it flits around all over the place. It's portable, likes to travel, so it does have its advantages. It can be annoying as well a little bit on your lawn once in a while. So how do we reconcile these two tests? One of the things that our lab's been looking at is the hybrid POCUS to echo protocol. So what we've been doing is bringing our in-hospital echo lab and looking at its ability to conduct POCUS when needed, because there is an opportunity where POCUS may help. And so it's an innovation in workflow. So our objective was to evaluate the feasibility of expert POCUS in certain situations listed here. And what we found, this is how our system worked. So we had a POCUS hotline. People would call us from different hospitals. Within the hospital, we would rush in, do a POCUS, and it would help us decide, do we really need an echocardiogram here, maybe in a couple of days, or do we need it right away? So this is how we integrated POCUS with echocardiography. And we got some good results, and this was presented at the Canadian Society of Echocardiography. So it's sort of a new disruptor. We really have to become the Uber of cardiovascular ultrasound, not just providing echo, but helping in terms of providing point-of-care ultrasound technology. So when you think about hybridization, Bonita Anderson talks about the platypus. That's an Australian thing. We have what's called the goose, which is this hybrid between the beaver and the goose. So just in terms of the time, I'm going to just talk a little bit about a specific example. The American College of Radiology developed guidelines for radiologic services. These were instituted at the Brigham's Hospital for all patients, regardless of the payer. And what happened was that a physician could not order a test if that patient had had a similar test previously using the EMR. So they were blocked from ordering a test based on these guidelines. This is the direct quotes from the report. The system improved patient safety and outcomes, but it did irritate the physicians. Revenue has also taken a hit. So-called low-value tests have declined. More appropriate tests, but crankier physicians and foregone revenue. You all know what we're talking about here, right? Insurance companies were the major financial beneficiaries. So some things to think about. And this is what they present. They say that there's all this benefit. There's benefits to patients, payers, suppliers, society, benefits to providers in terms of patient satisfaction and rates and better care efficiencies. But I'm not sure if that's really how providers benefit. It seems more like patient benefit. I don't really see where someone's job might be getting easier from day to day. So this is sort of the other side of value-based care. This was a New York Times article. They had to shut down the comments section because so many physicians were agreeing with this aspect of this. And the fact that this business model is being thrust upon them, and someone has to pay the price. So where's that price coming from? Something to think about. ASE has done a great job. We've been thinking about this for a couple of years, so I just point you to this summit that occurred in 2014 that was published in JACE that informed a lot of my talk. What I learned from that document was that we need to behave as we're part of a large organization, do good cardiac ultrasound, standardize your protocols, implement appropriateness, stratify your service options. So don't do a full echo when you don't need to, but think about where is it best to be done. So this is what I think, in terms of the theme of the session, the future is going to look like. This sort of idea of a hub and spoke model where POCUS is part of this. There's some risk sharing. There's multiple disciplines contributing to this hub and spoke. We're going to have to do some cost analytics, some outcomes, some populations, studies, continuous quality improvement. And of course, there's going to be a overlying voice that's going to be helping us with AI, overlaying all of this and helping us manage some of this complexity, I believe. So Echo in a value-based world, I feel, is very well positioned. Our product is a good product. It has a low fixed and variable cost. We are continuing with innovation and quality. And after doing this talk, I really recognize the advocacy work that ASE is doing, and I really understand why it's so important. Thank you.